our webpage as well after the meeting.
Great. Well, why don't we go ahead and get started? I'm going to just introduce myself. For those that don't know me, I'm Catherine Thibodeau. I am the Vice Chair of the Central Service Workforce Advisory Committee, and I will be facilitating today's meeting. Welcome to the public that's here. We're going to start off by introductions, and we have a pretty robust agenda today. We have a lot of individuals reporting out to committee members, and in our agendas we have opportunities for public comment kind of spattered throughout the agenda. So if people have something that they want to comment upon, and it's in a certain spot on the agenda, they don't need to attend the whole meeting to get to the public comment piece. So first, with introductions, I think just to get order, why don't we do introductions in the room here? So some people are here in Augusta in the room, and then there's others on Zoom, and I can call on people that are on the screen. But let's start here in the room. To my left, Laura, would you like to introduce yourself?
Sure. Good afternoon. I'm Laura Cordes. I'm the Executive Director of the Maine Association for Community Service Providers, MAXB.
I'm Kim Moore. I'm the Director for the Bureau of Employment Services here at the Maine Department of Labor.
And I'm Angela McLithis-Jean. I serve as staff to this committee, so I'll be taking notes and making sure our video gets posted at the end. And it can help with any kind of tech issues that folks are having. So if you're having some kind of screen sharing issue, I'm here for you.
And Jess, do you want to go next?
Sure. Hey, everybody. I'm Jess Maurer. I'm the Executive Director of the Maine Council on Aging, and I chair the committee. And I'm very, very excited that Catherine wanted to run the agenda today.
And let's just go around screen. Mallory?
Hi, I'm Malory Shaughnessy. I'm the Executive Director of the Alliance for Addiction and Mental Health Services, which is the statewide association of providers of community-based mental health and substance use treatment services, both outpatient and residential.
Great, thank you. And people just flipped on the screen. Michael, you're next on my screen.
Yes, hi, I'm Michael Smith with Catholic Charities Maine, serving as our Chief Program Officer, and for this committee, oversight of the Independent Support Services, or the Homecare program.
Great, thanks. And Chris, you're next.
Hi, I'm Chris Costello. I'm the Director of Quality and Compliance for Maine Health's Home Care and Hospice programs. And I'm also a board member of the Maine Home Care and Hospice Alliance. And I'm here representing both agencies today.
Thanks. And Angela?
Hi, good afternoon. My name is Angela Westhoff. I'm the president and CEO of the Maine Healthcare Association, and we represent 200 long-term care providers, including nursing homes, residential care facilities, and assisted living providers. Thank you.
Great, thanks. Dylan?
Hi, folks. Dylan Murray, Legislative Liaison with the Maine Department of Labor. I am staying off screen. I'm not feeling well. Been sick with COVID for the past week. But I'm happy to be here and support the committee in any way I can. Thank you.
Great, thanks. Sally?
Good afternoon, everyone. My name is Sally Weiss. I'm Vice President of Workforce Policy and Strategic Initiatives at the Maine Hospital Association. And we represent 36 hospitals across the state.
Great. Abby?
Hi, everyone. I'm Abby Stivers. I'm the Director of Workforce Initiatives at the Office of Aging and Disability Services, and I represent the DHHS on the committee.
Great. Paul?
Good afternoon. Paul Saucier, Director of the Office of Aging and Disability Services, and happy to be with you today to share some data on access.
And Mary Jane, I think you're the last.
Hi, Mary Jane Richards. I'm the CEO for North Country Associates. We had 17 last week, and now we will soon to have 16 facilities, long-term care and residential care. And we also serve people with developmental disabilities.
Great, thanks. Thanks, everybody. I think if I missed somebody, just give a shout out. one of the things that we're really excited about today is to have our sector-specific updates, and we have a robust representation to give us updates on the different service sectors that represent the essential support workforce. And I'm just gonna go start off with Angela, if you from Maine Healthcare, can you give us your update?
Sure, thank you. Thanks for the opportunity to be here. So as I said, my name is Angela Westhoff. I work with the long-term care community. And I'll just share some statistics, both nationally and state-based. And then I believe you also wanted us to touch upon some strategies that our sector is working on to address the workforce issue. I think most of my colleagues on this call will also probably start out by saying that healthcare workforce shortage existed long before COVID, but COVID certainly exacerbated those challenges. And for us, when we look across the healthcare continuum, we know that long-term care was hit really hard. Specifically from February of 2020 to September of 2023, nursing homes in Maine lost approximately 12% of the workforce. So when we look at Bureau of Labor Statistics data, we know that that was nearly 1,200 workers that departed from long-term care. Nationally, that was about 15% of the workforce for nursing homes left, and about 6.7% for assisted living. So a little bit lower, about half, if you will. I would just also preface my comments with saying that obviously this is a really important discussion because the ongoing labor shortage and the recruitment challenges ultimately impact access to care for residents across Maine. Some stats, I could pepper you with numbers all day long, but I'll just highlight a few from a very recent survey that the American Healthcare Association and the National Center for Assisted Living, so that's our sort of parent national organization, they released a survey on March 4th of this year, so just a few days ago, a couple weeks ago actually. 99% of nursing homes across the country are currently hiring. Probably not a shock to anyone here. It takes months for most nursing homes to fill an open position, and I think the same is true for residential care facilities and our assisted living providers. 46% of long-term providers are having to limit admissions due to the labor shortage, and more than half, actually almost 60%, have a waiting list for new patients and residents. Again, that's at the national level. In December of 2023, Maine Healthcare Association surveyed our members. And as I mentioned at the introductions, we have about 200 members. We represent all but one nursing home and about 120 or so residential care providers. So of that survey, 86% of our members, so both nursing home and res care, are experiencing a staffing shortage. 62% would describe their staffing levels at either a crisis or that they're very concerned about staffing. 35% of providers in Maine indicated that they were limiting admissions due to lack of staff. And I know we're here today to talk about direct care workers, essential support workers. And so we asked them to break down by position type, what is the position or positions that are most difficult to fill. So CNAs, certified nurse aides, are the #1 sought after position, and 92.8, almost 93% of providers say that they have significant vacancies for direct care workers. The second most popular category at 59.5 or 60% are RNs. Followed by dietary staff at 57% and LPNs at 35%, activities professionals at 26%, and then maintenance at 14%. So I think what's important to highlight there is that it's not just direct care workers, but I know this group is very interested, of course, in the essential support workers. A couple of other things I would just say quickly about workforce, and I know we each have about 5 minutes, so I'll move it along. I see Jess smiling at me. So the number of homes that are reported having to use temporary labor. So we talk a lot about TNA, temporary nurse agencies, or contract labor, however you want to use the correct terminology. But about 60% of our homes have indicated that they've had to resort to agency to fill positions within the last year. One thing that we also talk about a lot in long-term care is the impact on agency on regular staff morale. And half of our respondents said that agency either has a significant negative effect or it has worsened morale for their other staff that are on their teams. We also have some data around the cost, right? Temporary labor isn't free, and it certainly isn't cheap. And so we know from looking at cost reports from 2019 to 2022, which is the most recently available cost report, that the use of temporary labor grew from 49 million to 149.9. So that's $100 million explosion, if you will, in the cost of temporary labor. We have done some work around that in collaboration with the department. LD 451 passed in the last legislative session, and that's a great first step to collect data around what this looks like. And we are very grateful for all of the staff that are working in our homes, because without them, we wouldn't be able to take care of the residents. But we just know that it's very costly. And that money in turn is not being paid to those hard workers. Oftentimes, the 2 and 3% or 2 and 3 times the regular wages is being kept by that temporary agency. So we're starting to do work around that. And I just wanted to highlight that. The other thing that I would say is just Mary Jane alluded to, the changing number of facilities. I think you're all well aware that we have experienced a cascade of closures. Certainly the pandemic has created conditions with which homes are closing at a rapid rate, but there have been now 25 facilities that have either closed or announced closures since 2014, 10 of which in the last 3 years since the beginning of the pandemic, and 3 closures have been announced since the start of this legislative session. So, there's not a crisis on the horizon. We are in the crisis now. So what are we doing about it, right? So we can talk about doom and gloom all day long, but what are the strategies that long-term care providers are starting perhaps to see some success with? I would say throughout the pandemic, use of one-time supplemental monies were utilized successfully for recruitment and retention bonuses, sign-on bonuses. Most providers now have some sort of earn and learn program where they're bringing CNAs in, they're earning a wage, and they're able to be trained on the site. Flexible shifts are becoming something that I think providers have recognized that workforce needs, right? To have 8 hours or 12-hour shifts, maybe that's not palatable for folks. So chunking them up, whether it's 4 hours or 6 hours, something different. This is new that one of our members has shared with us, and maybe others on the phone have arrived at this faster than we have, but pay on demand. So for this direct care worker, essential worker population to be paid every day, so that you have income coming in and you're not waiting for a 2-week, for example, pay period. And we know that this population oftentimes have challenges with housing, transportation, childcare. So if you were receiving some portion of your income on a very regular basis, could you better meet those expenses? Benefits, now offering flexible savings accounts, including medical dependent care. We're also seeing the continued use of shift differentials, whether that's $2 an hour more or $6 or more an hour, trying to get those difficult overnight shifts filled. Paid time off, 401k retirement plans with employer match. I would say that not everybody is able to do that, but that's certainly something we are seeing more of, recognizing that we have to invest in our workforce to be able to adequately address this shortage. And tuition, whether it's investing in tuition reimbursement, some sort of educational support, but we talk about career lattices and career ladders. I think recognizing that we have to invest in our workforce for them to stay and be part of the growth and the expansion of direct care workers for the state of Maine. We just have to find more people. We need more bodies in Maine. But with that, I'll close. I'd be happy to take any questions. Thank you for the opportunity.
Great, thanks, Angela. Does anybody have any questions for Angela before we move on? I had one question. It was early on in your list of strategies that have been effective, and then you went on and listed a lot. And so probably the question would be the same for all of them, but for the earn and learn programs that are, what is the funding mechanism for all of these initiatives that you have been able to put in place in the long-term care? What pays for that?
Yeah, I mean, it's just their regular payer source. So whether it's the main care rates or other resources, I mean, there's not any magic pot of money that's coming. It's not a grant. It's not some special resource that we're able to tip into. So providers are having to figure this out within their existing means. I would acknowledge one-time funding, so I think most of you on the call are aware that, the department has administered, whether it's through an extraordinary circumstance allowance or some other one-time supplemental money to help with increasing resources to providers. So when you have one-time money, right, it's really difficult to raise the base wages for workers because you don't know when the next one-time money may come. So if you bump someone up from, $18 an hour to 20, nobody wants to go backwards in wages. So oftentimes providers would look to some sort of a bonus situation where they could bonus out those resources to their workers.
Okay, great. Any other questions? All right, next we have Chris from the Homecare and Hospice Association. Do you want to go ahead?
Sure. I do have a few slides if I can share my screen. Let me see if it lets me.
Yeah.
Does that work?
Sure does.
All right. So I'll just start by talking a little bit about who we are. Maine Health. Yep.
Could you put it in presentation mode?
I can try. See if it puts it on the right screen here. It flipped my screen around here. Let me. Is it hard to see this way?
No, this is fine. I mean, usually if that's perfect. Beautiful.
Okay. Sorry, it flips to another screen when I put it in the other mode. So just to talk a little bit about our programs. So Maine Health has two home health and hospice agencies: Community Health and Nursing Services, known as CHANS, and Maine Healthcare at Home. We are Medicare certified providers for both home health and hospice. And for Maine Care beneficiaries, we provide services under Section 40 and Section 43. The service area we cover is Southern Maine, York County, all the way up to Waldo County in coastal Maine. Every day we have about 1,200 patients on census, and every day we do about 500 or so visits total. Relatively small portion of that is essential care workforce, but particularly for hospice, it is a very important proportion of those visits. So in terms of the roles that we have in home care and hospice, there's really two roles: hospice aides and home health aides. I added utilization just to kind of show the differences between the programs. For hospice aides, we do on average about 2 visits per patient per week. Our aid visits. For home health, it's much lower, less than 1 per month. In terms of the job requirements for those positions, they are typically certified nursing assistants. So requires high school diploma, certified nursing assistant certification, and then for home health and hospice requires a driver's license as well. In terms of job duties by regulation, these are the job duties that they typically cover: is hands-on personal care. That's by and large the majority of the service that these folks provide. But also performance of simple procedures like venipuncture or point of care testing in some cases. Also assistance with walking or exercise. And they also do have the ability to administer medications that the patient would normally take themselves, although we don't take advantage of that very much. In terms of recruitment and retention, we're actually in a pretty good place at Maine Health. We have 3 openings there. One of them has been open since November, so there are some cases that it's still difficult to fill. This is in all the positions we have are in our more rural areas in Knox, Waldo, and Lincoln counties. The way that we've been able to fill positions is really been by word of mouth or employee referrals or transfers within our health system. And some of the things that we've heard from the folks who come to us are that they want to work in a non-institutional setting. You know, they want to be able to see folks in their home. And then there's some flexibility with schedule that comes with that as well. In terms of the perspective from other Alliance members, most of us, some of us are operating in a health system. Northern Light is another example. They have 7 essential workforce openings right now, and again, its focus is in the rural areas. That's where most of the openings are. But even in their South Portland area, for example, they've had a position open for 9 months now, unable to fill it. So it's not just the rural areas, but rural areas are certainly harder. Retention at Maine Health has been good. We're at 16% retention, turnover rather, in the last year with an industry benchmark at 22 to 34%. Again, subjectively, the leaders do note some generational differences. So the younger crew tends to turn over a little bit more readily. And some of the important things that our leaders have noted for retention are really building relationships with the care team, with the nurses and therapists and social workers and other team members that work with us, and also a connection to the patients they serve and a connection to the mission of our organization. Just to note that we did previously also employ personal support specialists, but both of our agencies have closed their private duty care programs in the last several years, partly because of difficulty filling the positions needed to care for those patients. I also did just want to end with a system perspective. Again, we are part of a health system here. And again, some of the folks that we get coming to us are from other parts of our system. And so the Maine Health System has 257 certified nursing assistant openings right now, with an average of 69 days that they've been open. The system has engaged in significant efforts that focus on, again, as you can see here, raising awareness about healthcare careers for students, starting with middle school students, trying to get in front of those students as much as possible and trying to get the message out about healthcare careers. We've supported internships and apprentices in clinical education for those students who have chosen a healthcare path. We've worked on embracing diversity and engaging diverse populations of Mainers in recruitment and training strategies. And then we've provided program support to the training and education programs across the state. The challenges that the folks doing this development work are encountering are lack of skilled educators to teach in the programs, lack of space, equipment, and funding for the training programs, and then once we've trained folks, holding on to them once their training is done, so that they end up being employees. And I do have a couple more supplemental slides. I can provide these in an email or whatever if you're interested in just some supplemental slides on those training programs and so on. But I'll stop there for now and happy to answer any questions.
Great. Thank you, Chris. Does anybody have any questions?
I just have a quick clarifying question. Chris, when you said I have two quick questions, clarifying questions. When you said that you only had 3 openings, I think it was, versus the system-wide 257. What's the 3 number for?
The 3 is for home health and hospice.
Okay, got it. And did you say Chan's is no longer offering any PSS services?
Right. Either
Wow.
Chan's closed our private duty program in 2022. Maine Healthcare at Home closed theirs in 2018.
I knew about that. I didn't know about Chan's. Thank you.
Yeah, sure.
Does anybody else have a question? I have one, again, a clarifying question. When you went, just so I understand, when you said the home health aides average less than 1 visit a month, what does that look like? What are they doing?
Yeah. So again, that's really a reflection of the fact that not a lot of our patients are getting aid services in home health. And so if you average it out across all the patients that we see, it ends up being less than 1 per month per patient. But again, a small percentage of our patients are getting. So the patients that are getting service are typically getting once or twice a week services.
Oh, okay. Okay.
And typically for showering and assistance with showering and dressing and things like that.
Okay, thanks. If there's no other questions, we'll move on to the next person on our list, and that's Laura Cordes. Laura, would you like to come?
Sure, thank you. It's good to be with you all this afternoon. I feel like I'm at an odd disadvantage being in person, which is a unique experience. So it is nice to be with you all, both in the room and on Zoom. The Maine Association for Community Service Providers, to take a step back and just ground people in who we are, we're an association of 90 individual community-based organizations throughout our state. We're all focused on supporting people with either intellectual disabilities, autism spectrum disorders, or brain injuries. Our providers support both adults and children, but I'll keep comments focused on the adult population. The conversations we're having about the workforce, I just want to take a moment to thank everybody on this group for the work that they're doing and for having us here today. As Angela said, our challenges predated the pandemic in our sector, the IGD sector, where our providers are doing a whole array of services with the ultimate goal of supporting people with community engagement, belonging, and greater independence, and whether that's community and work supports or residential services, some 24/7 supporting people in small group homes with the highest needs, or in something, a service called shared living, where individuals are supported in homes, in a private home, supported by a contracted provider. The loss among direct support professionals is the term that we use in our sector. Throughout the pandemic, really through the end of 2022, was about 30%. We've maybe regained a little of that, but we saw a lot of collapse and closure of services, some that just have not really rebounded. So we're still experiencing that shortage. Last year, MAXB members reported the first ever shortage of Section 13 adult case managers. I know that isn't necessarily under the umbrella, but it is a required service for folks under Section 21 and 29. MAXB works to do surveys of our members every year or every 6 months. So a lot of our data, except for some data that I'll reference that was very recent, comes from last year. And I will provide, some of the points that I've made on that fact sheet out to this committee as I look across the room. And yes, that'd be helpful. I'll send that out to you all. A couple things that I would highlight about the bonuses and the increased reimbursement rates have really been welcome, and they have been secured for some services, but providers continue to report that the inability to offer competitive wages is a leading cause of workforce loss. We have been struggling with, hiring folks at that 125% of minimum wage, but also needing to address wage compression and recognize the retention and reward of folks who've been in our service sector with certainly more enhanced wages and benefits. And in our sector, I would say anybody could benefit from having employees who have been with them for a long time. With people with disabilities, their ability to thrive in the community is based on a level of trust from people that they work with and count on a day-to-day basis for many of the people we support. So we're always looking certainly at retention, not only because it saves money on retraining, but really the quality of the lives of the people that we support is based on the folks that they interact with day to day. DSPs are working an extensive amount of overtime still. We have not seen that go down over the last couple of years. That's certainly leading to burnout, but they are doing their best to cover vacant shifts. Providers report at this. We talk about, hey, we've done some great work to get COLAs, to have a rate setting process that has helped, and certainly those bonuses from a few years ago to help some stabilization across the board. But when we talk about stabilization, we're really talking about the overwhelming majority of our providers striving just to meet basic health and safety requirements. When we strive to fully support people to be integrated and have person-centered services, and to actually be able to support people fully with their authorized hours. So one thing before I talk about those authorized hours, because Maxby has done some work among our members just to look at what is known as kind of that care gap. So are we able to meet 100% of folks' authorized or approved hours for any specific service? But we have been looking at our turnover rate, and while we are about 19% in the last year, you know, that is about half of what we see with our peers nationally. You know, we've maybe stabilized on that front, which, you know, may be a bright spot of good news, but I'm always reminded that, you know, what we were comparing it to was, you know, during the pandemic when we were looking at 27% and higher in turnover because of reasons that folks are very familiar with. So let me take a moment to talk about the care gap data that we have that is merely a snapshot, but we took a survey of our members, and 25 organizations provided information about the care gap that they had within their agencies when they looked across. And these are services. Every agency might have a different combination of services that they're providing. These particular 25 organizations had one or more of the following services: agency home supports, which is group home services, community supports, and quarter-hour home support. So someone going into someone's individual home and supporting them there versus someone living in a provider supporting a group home in the community. And among these 25 organizations, an additional 293 staff were needed to fully support 1,557 people. You know, and I say that, so that's about, when we looked at those 25 who were employing 2,388 people, that 293 full-time staff or FTEs, you know, that's about 12% of you know, who they're missing. Now, we do have some data looking at that we could extrapolate, and I'm happy to do that, you know, looking at, okay, so we have these 25 organizations, let's say agency home supports, there were 528 individuals supported. Well, that represents about 24% of what the department reports of the 2,155 individuals receiving that service. Because so we could do some extrapolation there on the care gap, but I thought it was you know, relevant to this discussion, coming up short for people who have approved hours or authorized hours, and where we're falling short. In terms of our association and our supports of our members in terms of supporting their workforce, you know, I think it's already been mentioned what people can do for benefits. I know that predates certainly the pandemic when folks were stretching to offer benefits and expand on those. MAXPE over the last 3 years, ourselves as an association has started a 401k multiple employer plan, which we have about 10% of our members participating in. Audits for 401ks can be expensive. When you share the 401k, those costs go down. So that's been a cost saver, plus getting folks into the plan. It's been a benefit for DSPs across the state. I want to thank the department for their support of a training and technical assistance project that's underway for provider organizations that are new Mainer or immigrant led. We have about 16% of our workforce identify as new Mainer or immigrants. We certainly, as an organization supporting people in the community with disabilities, understand the need to increase a community sense of belonging, just as residents of Maine, but certainly when we think about new Mainers and immigrants in our workforce, this was an important project to support folks who've been in the field, who started their own organizations, and see this as a career. We also have a project that we're looking at for the next year that would focus on leadership development skills to keep folks in the field. And I will wrap up because I have likely gone over and just say we have been able to organize conferences focused on leadership development, management of folks so we can improve retention in our field. And we were really pleased last year to, while there are multiple training opportunities for a direct support professional, bringing them all together, we held our first statewide direct support conference so folks could see themselves as part of a larger network and a valued part of the direct care workforce. I'm happy to answer any questions you might have. Thank you.
Great, thanks, Laura. Are there questions from anybody on the screen? Okay, moving forward, Mallory, would you like to give your update?
Sure. So Malory Shaughnessy with the Alliance for Addiction and Mental Health Services. And I've been working, we've done some internal surveys amongst our membership. We have 35 member agencies across the state, but we're also working with the NASW Maine and the Psychologists Association and some other groups in a behavioral health workforce coalition that we just did a point in time survey of the state of Maine on some of the vacancies and lack of staffing. It's more geared in some ways towards the clinical, but I will share a couple slides from that as well as some key data from our internal agency. And I will go ahead. I clipped a couple of slides from a presentation of the preliminary on our point in time survey. I will share my page here. So just to kind of give a bit of an overview, can folks see that okay? So job titles within the mental health field, mental health and substance use treatment, are not as sort of organized or set. So they vary considerably by agency, what they call different staffing positions, and by service. Obviously, some, like a CNA, is going to be a CNA, no matter where you are. But a MERT-C, which is a mental health rehabilitation technician, conditional, MERT-Cs, BHPs, behavioral health professionals, and CNAs are sort of the bulk of sort of the direct service organized titles. But then there also, you'll see mental health support specialists, residential support workers, mental health aides, residential mental health technicians, mental health direct care professionals. People call them different things. I know in some industries it's more sort of formally attributed what things are called, but they vary considerably by agency and by services. Some key data from our, and just some of the services that we provided, because not as many people aren't as familiar with sort of the behavioral health services that are out there. So there are, basic adult and child residential mental health services in small group homes and in larger centers. Substance use treatment, we have medication management in the community, outpatient therapies, in-home child and family treatment, like the home and community treatment program, which works with youth that are at risk of destabilizing and often escalate into an emergency room visit. So home and community treatment provides clinicians and a direct behavioral health professional support person that come into the home and work with the family and the child. And that's across the state. We have those supports for daily living in the community, case management services, specialized intensive community services for people with severe and persistent mental illness, like an ACT team, which is a assertive community treatment. And there's many people on that team, including some direct support folks, and medically managed withdrawal. So there's a wide variety of services that are in the behavioral health realm. Some key data from a recent Alliance Agency survey of our internal survey was 100% of the agencies reported staffing shortages. 86% reported critical staffing shortages that were severely impacting access to care for a lot of their services. The range of 25 to 45% for residential services, support staff, a range of 35 to 50% vacancy for in-home support services. Vacancies for these support staff remain open, sometimes up to 2 years, but on average, somewhere between 8 and 18 months, depending on the area of the state, with obviously more trouble in the rural areas, Western Maine, up north, down east. And turnover rates in support staffing have been averaging around 40 to 45% annually right now. So retention is a major issue as well. In a recent sort of audit that we did, we had 38 adult mental health residential beds empty due to lack of staffing. I think that has shifted just a little bit recently, and we had about 25 child mental health residential beds that were sitting empty because they didn't have staffing for them. One agency had a whole wing that they had just had to close down because of that. And, this is all while we're hearing from the hospitals of the issues with children and adults both getting stuck in hospitals for extended stays of months at times. So some of the slides from our workforce survey, we surveyed 50 agencies responded and 277 individuals. And the number of persons waiting for services by service type, with substance use prescribing, mental health, counseling, peer support, case management. By far, mental health counseling was the largest. We pulled out some of the actual numbers for a few of these. So almost 9,000 people waiting for mental health counseling, close to 3,000 for psychiatry, case management, individual providers. The wait lists are huge across the state of Maine right now. We look at average wait times. We're talking around, 32 plus weeks for mental health counseling, prescription prescribing, individual provider first visits. It varies quite a bit, but, extensive wait times as well as wait lists across the state. So these are just some snapshots of behavioral health agency staffing. 35 vacancies for every 100 mental health clinicians, 41 vacancies for every 100 management positions within the agencies. The added staff needed to meet demand is quite extensive. And the last one here is a little scary too, because we look at the age of providers and 40% are age 60 and over, and 45% of those plan to retire in 5 to 10 years. So we have a bit of a cliff coming in our direction in this field. And that, I will stop sharing. That's some of the highlights from our point in time survey and from our individual agency surveys. So similar to what Angela said, what do we do? How do we get innovative? How do we think about, strategies to start addressing this? And I want to really do a shout out and thank the department. We had a great meeting yesterday with Paul Saucier was there, Office of Behavioral Health, Office of Child and Family Services, Maine Care Services, had a really good meeting to start having some bidirectional conversations. And I think workforce, as you noted, Paul, workforce really, rose to the top of the issues that we need to be discussing. Access to care because of workforce are major issues. So some of the ideas are, as others mentioned, monies for recruitment and retention bonuses. Those helped quite a bit when we had those coming in during COVID. Reductions in administrative burdens in reporting and duplicative assessments. That causes a lot of burnout on staff who are in this to be working directly one-on-one with individuals or children. They want to help people. They don't want to sit around doing a lot of reports and paperwork. So it really does impact the burnout that they face. Interstate compacts in any way we can get them so folks can move in and out of our state or do telehealth. The idea of creating teaching agency designations has been doing in Washington State and a few other places, similar to teaching hospitals, where there could be a designation and a main care rate for agencies that largely serve that population to do supervision and training in-house. And then, similar to what was done in the construction industry a few years ago when they couldn't get folks coming out of high school and community colleges to do the work, but to develop behavioral health training programs at the CTE centers across the state. There's actually only one in the state right now that has a behavioral health sort of introductory program at this point. So being able to expand that are just a few of the ideas that we have, but we got a lot of work to do. And that's mine.
Great, thanks, Mallory. Any questions from the group?
I'm sorry. I was saying.
No, go ahead. Angela, go ahead.
I would say not a question for Mallory, but just wanted to echo Mallory's comments about burnout. I didn't mention that in my survey results, but when we ask members to identify the reasons why they think staff leave positions, for recruitment and retention purposes, but really retention, burnout and stress is the #1 cited reason. So I just wanted to underscore that.
Yeah, stress. And a lot of that stress, there's, administrative burdens of paperwork and things like that. But a lot of the stress, too, is because of the shortage, people having to work double and triple shifts in residential to keep them, able to stay open. So a lot of double, triple shifts that we're seeing.
And this is just on that point, and I think I know Sally's coming up, so I'm teeing up a little question. And Chris, you might even have some thoughts on this too. But we've also heard, and I think it's more anecdotal, although there's a lot of information out there about the quadruple aim is the fourth part of the aim is clinician, sort of satisfaction with their role. And we've been hearing specifically LCSWs in hospitals or health systems leaving because they can't find care for the people that they're trying to serve, and it's like extraordinary burnout.
Yep.
So I don't know.
Unable to shift level of care.
Right.
If they're getting a level of care here, and I know they need to go either to a higher or lower level, but there's nothing open anywhere. And yeah, that's very stressful for folks.
I think they call that moral injury.
Yeah, exactly.
Yeah, exactly.
No, they really
no, that is literally
it is
a real thing. Yeah.
When you enter a profession with specific goals to serve, a population or provide specific services, and you literally cannot do it because of the lack of resources or capacity or whatever it may be, and just that ongoing running into walls and not being able to fulfill your purpose. They call that moral injury.
I hadn't heard that one before.
Very real.
It's real.
Yep.
Chris, did you have something to add there?
I was going to say that exact thing. That's we've been addressing it in the context of moral injury. Yeah, that exact thing.
Okay, great, thanks. Mallory, I had a question. This is probably a little self-serving for as I have a family member who has severe and persistent mental illness. But I'm curious, and you think I would know more than I do, but I don't know a whole lot about the service delivery system. This individual does not live in the state of Maine. But what is the impact to the member when they do not receive that whole list that all of those people that were seeking, like counseling and the different various services, what does that translate to the individual?
Oh, well, it varies by what the issues or the challenges that they're personally facing. If somebody has a schizophrenia or something that can have psychotic episodes, each time you fall into a psychotic episode, you have brain damage as well. And it exacerbates your situation over time. So without getting a consistent, like assertive community treatment team to do wraparound services for you and keep you stabilized, keep you on medications, each time you have that psychotic break, it does damage and it makes your situation worse, your challenges worse. And the younger, there's a lot of research on like first episode psychosis, that if we could just get to kids when they have that first episode psychosis and get them that kind of treatment and medication and things that they need, long-term prognosis is drastically different than if they don't receive it until much later and have had several episodes. So, research shows that there's a huge impact to them. But, for folks that are just trying to get some outpatient care or therapy, or they have a child who is suffering from, severe anxiety, we see a lot of that has increased since COVID, severe anxiety or depression. Those kids, without getting some kind of intervention and being able to get that support and the support for the family on how to work with them and help keep them stable, we see them escalate repeatedly. We've got hundreds of kids right now sitting on a wait list for home and community treatment. We don't have enough BHPs, behavioral health professionals, in the state to do that work. And Sally will tell you, those children escalate in and out of the emergency room because they're not getting the supports and their family's not getting the supports to keep them stable in the community. So yeah, there are major impacts on both quality of life, activity, and capacity to be a productive community member. It's huge. I'm teeing you up, Sally, for the hospital issues where you get people that don't get what I need from my people.
Yeah.
They can't get access to it.
Why don't we flip it right over to you, Sally, then, to give you
Yeah.
a
So I think, hospitals have a slightly different perspective from the folks we've heard from so far, in that we're kind of the place that folks end up or are sitting, rather, when all these other organizations and providers have beds they can't staff or can't or are closing their facilities. I would just note, so just a little context. I mean, overall, Maine hospitals are in a better position than they were a year or 2 years ago at the peak of the pandemic related to staffing. That does not mean that we still aren't struggling with specific occupations, but overall, we're doing better. In fact, I had 2 hospitals just last week share with me that, one hospital went from 80 traveling nurses last year to 8 currently. And another hospital went from 45 last year to 12 at current. So it's a drastic improvement. That being said, there still are nurses that are needed. And I would say that now there seems to be a bigger emphasis on some of those support staff, CNAs, MAs, occupational therapy, physical therapy assistants, rad technicians, ultrasound technicians, some of those other types of roles that we haven't really heard much about, but are still really needed. I think one of the important things that we think about, hospitals do use CNAs and are relying more and more on CNAs. And I just want to point that out because those are also roles that are used in other healthcare settings. And that is primarily to expand the care delivery team on the inpatient side. So what we're seeing is more and more nurses being paired with CNAs. A lot of hospitals are looking to expand to LPNs again. So an RN, LPN, 2 CNAs for a care team taking care of, 8 to 10 patients on the inpatient floor, really freeing up everybody to kind of work at the top of their license And this gets a little bit to the burnout, the resiliency, trying to make people's work-life experience a little bit better. That being said, there are what I would call major throughput challenges at hospitals, or patients just being stuck. I would say on average, and any given day, there are probably approximately, give or take, 300 patients sitting in Maine hospitals that should not be there. They should be in another care setting, whether that be skilled nursing and long-term care, residential care, whatever that looks like. But there just aren't beds available. When I surveyed hospitals back in October, hospitals reported at that time that about 30% of patients, if we were going to take that 300, 30% have been sitting between 7 and 14 days waiting. 40% of those patients have been waiting between 14 and 29 days. 20% of those patients have been waiting between 30 days and 6 months, and 10% are waiting for 6 months or more. And so those are some of those patients that Malory, reflected on, as well as nursing home patients, that have complex comorbidities, and they need, lots, they might have multiple types of care needs, and there just isn't a nursing home bed that has that staffing capacity to care for that patient. And so they sit in hospitals. And the outcomes for those patients aren't good. It definitely impacts their quality of care. And I mean, I've heard anecdotally of adult and pediatric patients that have, severe behavioral health needs that have sat in emergency rooms for months, and not their fault, but they very often become violent. They assault healthcare workers. And very often when we do find a placement, usually sometimes out of state, maybe Tennessee or some other state, we then get reports back that those patients they're like a different person, right? Because they're finally in a setting where they're getting their needs met. They're outside, they're, integrated, they're getting activities, they're getting therapy, they're medication, all of it. So we know that those patients are not served in hospitals. I would just note that I think one thing that hospitals that I've been working on specifically at the MHA, and one challenge we've come across is Maine Health, for instance. Right now they have over 200 CNA openings across their health system. And they actually had to cancel their January and March CNA classes because they cannot find an instructor with 1 year long-term care experience. And this is a CMS regulation that requires any instructor that teaches a CNA class to have 1 year long-term care experience. And this is a huge barrier because as we have an older population, older nurses, and frankly, the folks that want to teach may not have that experience, but they may have other commensurate experience. In fact, they had found somebody who had a PhD in nursing and taught at USM and St. Joe's and had worked 4 years on a geriatric inpatient floor, and they still didn't qualify under that criteria. So it's kind of maddening. I would note that I am working with Senator King's office on that issue, and he and several other senators from across Ohio, Senator Brown, they've had other organizations reach out, including those healthcare associations. So kind of the equivalent of the Angela in other states have reached out and said, hey, this is a big barrier for our throughput. And, with Maine Health, they had 40 applicants waiting to go into a CNA course. And they're not able to do that. So I think that that's really important because I know that those are primarily going to be fed into the hospital, but when you think about how a healthcare workforce migrates over their career, it's not to say they will always be in a hospital setting. They very often will move to another setting over the course of their career. So I think it's important that we think about that. I would just note that some of the strategies, hospitals, homegrown programs, partnerships with adult ed, Maine Community College System, trying to figure out ways to expand training, earn while you learn, apprenticeship models, all of those things, tuition fully paid for. We have some hospitals that are doing kind of a dual program where they do ESL for those individuals that maybe are new to Maine or new migrants to Maine. So they'll pay them to work as like a environmental services and take classes as ESL, and then they upskill them when they're ready to like a CNA or an MA. So hospitals are getting very creative with how they're thinking about those warm bodies and who wants to join the healthcare workforce. And then I would just say ongoing, there is a lot of focus on resiliency. In fact, MHA and MMA just held a conference, Caring for the Caregiver, that was really focused on evidence-based research, looking at how can you move the needle on reducing burnout, moral injury, exhaustion, how do you build stronger teams? And not just kind of, let's do more pizza parties, but like, how do we really address this issue in a deeper way where it's sustainable and really makes a difference to the folks that are providing that care, because it's a hard job and we need them. So that's all I got at this point.
Great, thanks, Sally. That's really helpful. Any questions for Sally folks might have?
I have a quick question, which is to think, I'm just curious, Sally, if you and Angela have collaborated on, and it just is a model that Dartmouth Hitchcock uses, because nurses, a master in nurse, person who has a master's in nursing has to teach nurses, but they ended up paying, Dartmouth Hitchcock Hospital nurses to teach. And so, has there been any effort to sort of identify long-term CNAs in nursing homes that could be essentially, the nursing home could be paid? I know this creates all kinds of other problems, but if it's a feeder, right? Is there a mechanism to like try to recruit some? Because that is, by the way, one of the quality metrics, right? One of the pillars of quality that PHI has identified is sort of that being able to be a peer leader. So, is there something that you guys could do together to, sort of compensate people who are in that role, who are working in that role, but who could come out and train and then, go back into their job kind of thing?
Yeah, I don't know. I'll start. Sally, you jump in here too.
Yeah.
I think I would just go back first to the 1-year long-term care experience. So, I mean, we've had this conversation now with Sally and other hospital-related folks, and I just think it's important for the record to note that we didn't object to that removal. I mean, I think we're all in the game of training more healthcare workers, whether they end up in our sector or somebody else's. I think we all want what's best for the residents and the patients of Maine. I mean, we can't be obstructionists in this anymore. And I do think that other sectors, not just long-term care, are using CNAs more and more. I mean, that just increases the competition for these, but these workers, but for this, for the same reasons why we need to create pathways that are accessible and reduce barriers to this training. And Jess, I mean, I think you raise a really interesting question. We have talked about if you're a CNA and you've worked in this setting for 20, 30, whatever years, right? Why can you not train the next generation of CNAs? I mean, why does nursing faculty have to have a PhD, right? To teach other RNs that are I mean, I don't know. I didn't set these rules. I didn't make these regulations. I think it's worth having that conversation. And actually, in a discussion we were having with Senator King about workforce shortages and why nursing homes are closing at rapid rates, he said, well, I don't understand this. Like, help me understand this. So I do think there's an appetite federally, at least on the part of some lawmakers, to kind of question these long-held training requirements. I mean, obviously, access is important, quality of care is important. We want to make sure we're training the right people to do the right job and be successful and not harm patients. But I do think it's worth sort of lifting that up. Sally, I don't know what you'd say about that.
Yeah, absolutely. And I think, that specific CMS regulation is from 1987, when probably CNAs were used very differently and care was delivered in a very different way. And the problem is the regulation hasn't changed. But right now it requires to be a registered nurse with 1 year long-term care experience to teach a CNA course. And I think that is definitely a barrier. I mean, why not an LPN? Why not? I mean, there's lots of people that probably could be qualified to teach that course. In terms of more coordination, I think is what you're getting at, Jess, which is like, how can hospitals work with other sectors to support those, training programs and try to remove some of those barriers. And I think absolutely, I think in the 18 months I've been at MHA, that's kind of been one of my primary goals, which is to break down silos, figure out how do we leverage the resources there are. And honestly, shame on me, I haven't really talked to Angela specifically about, hey, do you have nurses in your nursing homes that would be interested in partnering with hospitals? But I mean, there probably is space for that for sure. And it may not just be CNAs. I mean, I know LPNs are also used in other care settings, and we only have 2 LPN programs in the state, and we have others considering opening up. So I think those are the things that we need to be thinking about and kind of collaborating and coordinating more on, and just having more awareness so that we can make those connections.
All right, thanks. So anything else from this group? And then I would suggest that we open up to the public for public comment. So we have our first public comment. So if anybody.
Can I just follow up on
Yes,
one piece? And Sally, it's just a point of clarification, because we have people outside of the healthcare world maybe listening in. MMA, when you said that, you meant Maine Medical Association, right? Not Maine Municipal Association.
Yes, I meant the Maine Medical Association. Yes,
Perfect.
in partnership with the Maine Hospital Association.
Beautiful.
Right. Yes, sorry about that.
That's okay. I'm like, when I think about like other people, they're like, because I had to do a double take because I work with both of them. I'm like, oh, right.
Yeah. I did that same thinking in my head. Okay. Do you see anybody? And
Yeah, so for attendees, you're welcome to raise your hand if you'd like to make a comment, and I can unmute you, but I'm not seeing any hand raises. There should be a little Zoom button at the bottom of your screen, and that kind of black bar across the bottom if you're looking for it.
Okay, we'll move along. If you had the agenda and you were following it closely, you probably noticed that I skipped an agenda item, which was our internal reporting as a committee on our annual report and our presentation to the HHS committee on our annual report. And Jess is going to give us an update on that, and then we're going to move right into DHHS updates, and Paul will be the next step on that. So go ahead, Jess.
Great. And I also wanted to note that we didn't offer Michael an opportunity to offer any updates around the Homemaker program. So I just wanted to say, I'll give you a 30-second heads up, Michael, that if you wanted to do that, we would give you that opportunity too, because we just didn't include you. And I don't know.
Yes. Does that mean I get 30 seconds to talk to?
No, you get a whole like 2 minutes.
Right. I'll give you at least 33 seconds.
At least, no, but I just think, because you were sort of included, we were thinking members of the committee would offer updates, sort of on their own, but I just don't want you to feel left out. And I feel like it's really important for you to also share where things are for you.
Absolutely appreciate it. I can be brief. So from a staffing standpoint for us, our direct care workforce, our homemakers that go into the home, we've continued to decline. Unfortunately, we're down to 75 pre-pandemic. Again, like everyone else, was not like we were fully staffed at that point, but that was 130 or so. And even this past quarter, we were at like 90. So we've lost 15 in the past few months. And this is all the while we have a person that we've dedicated to be a staffing specialist to focus solely on hiring. So we're looking at the entire hiring process from application to completion to see how many go through that, where they're falling off in the process, how long that process is taking. More proactive outreach when it comes to looking at those, for bringing in, right? So surveying our current homemakers around why are they with us? Why are they staying with us? What thoughts do they have around potential recruitment and retention strategies that we could utilize? Because they're the ones that are staying and are doing the great work that they're doing. We're also noticed too that there's a good chunk of our staff, the direct care force, that are rehires. So they will leave and come back. And so that's about almost 60% of our hires, if you will, are rehires. So really honing in on those. So at point of exit, if those that are voluntary leaving, kind of having that real one-on-one conversation on why are they leaving? What are those rationales? Is there anything we can do at this point in time to try to help them to stay? So we're taking targeted efforts on those fronts, certainly. On a very positive note, I will say when it comes to the greater kind of community, particularly within the PSS world, we've seen a pretty stark positive response in terms of their capacity and willingness and ability to take on additional consumers for us. So what this typically looks like, again, is that they're hiring someone and doing that higher level of care work, but to keep this employee, and they want to keep this employee happy and working, he or she might need an extra 2, 3, 4, 5 consumers a week. And so to fill them out and be full time, right? And so this is where we're picking up. So we're getting 5 more here, and can we get 10 more there? Can we get 15 more here? So those those are kind of buoying, if you will, some of the folks that we're not able to staff on our end. So they're still paying their staff at the PSS rate, which is higher than what we're paying for, which is what's attracting their workers and partly detracting our workers for that. But in the end result for me is we're getting consumer served, which is what we want to have happen, right? So I see that as a very positive trend in that respect. So yeah, there's my 2-minute update for you, Jess. Appreciate the opportunity. Thank you.
Sure, absolutely. And I will be super brief. I just want to say that thank you to you all for helping us and Angelina pull the report for 2023 together. And we did have an opportunity to provide that report to the Health and Human Services Committee, Catherine and I, on February 22nd. Some good questions. And one, one representative was a little challenged to say, we said we were particularly focused on. I mean, obviously this workforce, we're focused on everything, but we were really honing in on our work last year, which is to focus on if we're supposed to measure, right, how well anything that we're doing, whether that's through the state or privately, to increase this workforce without understanding what the baseline data is to measure from, we're really not able to do our work effectively. And so we kind of spent the last year trying to figure out, how do we know if we're making any progress at all? And so we are very focused on data that we have. And I think one representative was asking, what are you doing to look at the private gap? In other words, not people who are entitled to care in the state, but people who are trying to get access to home care and other supports, behavioral health in particular. So I just want to point out that our work has already been pretty challenging trying to figure out some of this information. And there's a desire, a little bit of a desire out there for us to go even further to figure out, like what's the private demand that's not getting met. I'm not sure how we'll do that, but we'll just want to flag that as a sort of a question that came up in that conversation. As I just want to offer another very brief update, which is, we talked about putting in a late session bill to have Maine Health Data Organization do an environmental scan, essentially trying to look at all of the data that is available to help us build what's called a care gap baseline to understand who's not getting care in Maine, and the number of hours they need. And so translating into us sort of the number of workers we would need to bring into this into this field or workforce sector, and then really measure against that data. Well, then we would build it, by the way, once once they told us what it would look like, right? So that's the first step, is to get Maine Health Data Organization to sort of do an environmental scan, find all the data there is available, and tell us what it would cost for them to build that, to build a care gap measurement that would be published annually. That bill went in late February. It is not, things are moving really fast there. As a matter of fact, the Health and Human Services Committees said they're done their work. So and the Legislative Council doesn't even meet until next week. So there's a good chance we're not going to get a hearing on that bill. And so we're looking at other ways around that. And we have a couple of ways. So we're working with the bill sponsor, Margaret Craven, who serves on this committee, and with the speaker staff. But at this point, we're just, it's a very interesting session. It's all I'll say about the session. It's a very interesting session. And it's happening very quickly there. And that's it. That's all the updates I have.
Thanks, Jess. I mean, I just think reflecting on the reports that we've received from all the different sectors, and the efforts within the individual sectors to obtain some kind of data is commendable for sure. That is, but it is there, it is fragmented, and it would be great, that is our hope, to be able to get some kind of consistent data metrics together to really be able to measure this. And with that, I'll turn it over to Paul. Paul's going to talk to us about some initiatives at DHHS, or some access measures there.
Yeah, so thank you for having me. And yes, I'll talk about what data we have shared to date, and then move into some of the newer things that we're now posting on our web, and finally finish with a couple of comments on the federal access rule, which I think is going to help all of us kind of move this discussion along. So I'm just going to share my screen here, and let me see. Bear with me for just a moment. Here we go. I want to start with the most recent quadruple A report. Whoops, I think you're probably seeing my email rather than, or are you seeing the?
We can see it.
Residential and nursing capacity at the top. Okay.
Yeah.
So for those of you who are not familiar, the quadruple A report is now been presented for 3 years. And so, these measures, it's not always clear what they tell us, and they're imperfect for sure. But we do now have data starting in the pandemic, and now as we emerge from the pandemic. And I would say that this year's report is quite consistent with what I've heard from all of you this morning. It's mostly moving in the wrong direction this year, right? After a couple of years of these particular indicators moving in the right direction, things seem to have plateaued and or turned the wrong way. There are some important exceptions that I'll talk about, but if we start here, this first table is assisted housing. And for people who aren't familiar with the licensure nomenclature, this is a very broad category that includes pretty much most residential care that is licensed. And so it includes PNMIs, waiver group homes that are licensed, assisted living. And you can see that this year, after having increased for a couple of years, the number has declined a bit of both facilities and of beds. So, hard to say what's going on there. What I would say is next year, expect to see this number drop even more, but because of a data anomaly, the mental health licensure is moving to a different category of its own. And so those PNMIEs and so on will be in a different category next year. And that is one of the challenges we have with trying to present longitudinal data, is the way it's categorized from year to year. But nonetheless, this one seems pretty unambiguous that res care capacity has declined in the past, in 2023. When you look at the residential level 4 facilities, and these are a subset of these up here, you see that there seems to be a slight decline there too. We present these differently because of the way they're reimbursed, we get occupancy data from the providers. So these are adult family care homes and PNMICs. And you can see that although the number of facilities declined, it looks like the number of beds has gone up slightly. That could be because some providers have consolidated beds in a single facility. We know that in at least a couple of the nursing home closure situations, it was a multi-level campus and some nursing home beds were converted to res care and added to the existing res care facility. So there could be a lot of reasons why these numbers are not necessarily inconsistent is what I'm saying. And certainly it's good that the beds do not appear to have gone down, but rather up. But you see here the occupancy dropping. This we were seeing a trend since the depths of COVID of occupancy increasing. That's clearly reversed this year, and you'll see it again in a couple of other categories in just a minute. When you have increasing number of beds, that could just be because the denominator is going up, but it certainly is consistent with what all of you have reported today, that the workforce shortage has not improved. When you get to NIFs, as Angela already reported, we've had more closures in the past year. We've had a reduction in beds. And the occupancy, again, after some increases, appears to have plateaued and or slightly gone down. The brighter spot, although there's definitely it's mixed news on home care. The bright spot in home care is that many more people were served in 2023. This is I was interesting to hear Michael talk about PSS agencies able to take on more. This is consistent with that. There are more people being served in home care. In fact, home care has added more people than the reduction in the res care and nursing home capacity. So that's a very good thing. You can see, and these are the Medicaid programs. Section 12 has been flat, but that's a pretty small program. Section 19, our waiver program, continues to grow. And PDN grew this year, although you're gonna see this number flatten and possibly decline for some time. What the bad news here, though, is that increasing numbers of these folks are getting less than what's authorized in their care plan. We don't know how much less, but we know that more people are getting partial care plans. So that's the trade-off there. I mentioned that 96, we're going to start to see a flattening and then a reduction. That relates to the service coordination. Service coordination agencies have stopped taking new admissions of Section 96 because the reimbursement is different than it is in our other programs. That service coordination is one of the things that is going through a rate setting this year. In our state-funded programs, again, you see increases, significant increase in Section 63. This is directly related to a significant increase in appropriation that we got in the budget last year. We are now, however, reached our sort of capacity, and so you're going to see this number flatten out as well. But again, we were able to completely eliminate the wait list and pretty much double the program in the past year. So that was a very positive thing. And Section 69, the program that Michael referenced, has been flat in the last year, slight decrease, wait list slight increase. And then Chapter 11, we're no longer going to be reporting on because that program was very small. We redid the rules and it's been folded into 63. So we won't see numbers there. But again, same pattern as with Medicaid here, you see an increase in the percent of people who are getting partial care plans. So that's what we have presented now for a few years in the Quadruple A report. I want to show you what we have been publishing quarterly on the web. These are all year-over-year numbers. They're helpful from a baseline perspective to see what the movement is. In our on the website, we've been working on some new measures that we're publishing quarterly. And let me just share again. Maybe I can find it. I apologize. I'm just trying to find the, let me go here. Okay, there we go. I'm sorry. Let me try one more time here. Here we go. People seeing HCBS access measures at the top. Okay.
Yes.
So first of all, the easiest way to get to this stuff is what I always do is I Google ODES data, and what you will come to is our there's a listing of data reports, and the Quadruple A report is there. But over to the right, there's a call out box and it says HCBS access measures, so that you can get to this pretty easily. So waitlist information we've been publishing for a long time in the IDD programs. And you can see that here. The big caution about waitlist data is, what does it really tell you? And that is especially true in IDD, because we have one program, Section 21, our big program, which has a long waiting list, but most of the people on that waiting list are receiving other services, and most of them are receiving Section 29 services, which is our other program. We've been waivers, as you know, are funded through appropriations for a certain number of slots. We have had new slots available in Section 29. And so you see that much smaller wait list there reflects that we're continuously taking new admissions in Section 29, whereas in Section 21, we only take priority one urgent situations. But nonetheless, we have several quarters of this data on the website. And the good news from our perspective is that this number, the total number of people served, continues to go up every month. And the wait list has been pretty flat for some time now. We've started adding the length of wait times. And you can see that this reflects what I just told you about the funding for those programs. So Section 21, if you're a priority 2 or 3, in other words, your needs are not urgent, you're going to wait 6 years or more for a priority 2 or 3 slot because they just don't get funded very often. They don't come up very often. However, Section 29, you can see 0.2 years. So what is that, 20% of a year. Because we're able to make offers if people qualify, and it's just a matter of hooking you up with services. We have started in the past year also publishing this waitlist data for our programs for older adults and people with physical disabilities. And so Section 19, as we noted a while ago, has just grown and grown and grown, which is a very good thing. No wait list. This could have a wait list if we ran out of money, because, you know, under federal rules, you can have wait lists on waiver programs, but we've been fortunate in Maine not to have to do that. And as I said, these are folks who are nursing home level of care. So there's probably been some substitution effect here, people who might otherwise have gone to a nursing home, but who are being served in Section 19. Section 96 is a state plan service. And that program has also grown, but as I noted earlier, we're going to see that flatten now as the service coordination agencies are no longer taking new referrals. Let's see, Section 63 and 11 are combined now. As I said, we don't have a wait list here, but we expect one to start developing again now that we've hit the sustainable level with our new state funding and then the Homemaker program. So what I really wanted to show you today, though, was this service data, which if you haven't been to our website in a while, this is new stuff. These are things that we have worked hard at and that we're able to do with our existing data, even though it takes a lot of effort because it's a manual process. This shows you, here what we've done is we've taken a 1-year time frame that's in the past, because we have to give claims time to catch up. There's a claims lag with all of this stuff. This is not the care gap that you're looking for, but it's a different measure. It's looking at, okay, in this time period, and this happens to be calendar 22, and we're going to update it by 1 quarter forward each quarter. How many new people were authorized for these types of services, and then how many actually received a service in that same time period? So you can see that we had 51 nursing authorizations, 39 were started in this time period of 1 calendar year. PSS, 302 new service authorizations, 269. And I would just note that you're always going to see some gap in this kind of study, because, you know, if the service is authorized on December 15th, the likelihood of you starting that service in December are low to none. So then if you look at, for the people who did receive that service, how long did it take? No surprise here, it takes longer to get a nursing service than a PSS service. 15.4 days on average to get a nursing service once it was authorized, 10.6 days for a PSS service. And so as we go, and there is this is the second quarter we've done this, so there's a prior quarter that's archived below. Again, we can at least start to see whether there's change and whether these things are moving in the right direction over time. So if we move now to the med assessments, we've had a lot of questions about, you know, how long are people waiting for an assessment for services? Never mind getting the service, how about just getting in the door? So here, this again, we looked at a 1-year period, the number of assessments that were completed, and then the number that were completed on time, and on time is a standard set in our contract with Maximus. So you can see that the on time is, you know, it's not 100%, but it's not bad. And then if you go down to looking at the average number of business days, it's 6.4 days from the time an assessment is ordered for an initial assessment. It's 12.6 for a reassessment, and then it's 2.1 for a hospital assessment. This difference here between the initial and the hospital and the initial, that's simply a contract standard. We require that hospital assessments be done more quickly than other assessments in the community. All right, we're getting through here. So now moving to developmental services, we've done a similar thing, taking a study period where the data was where it was far enough back in time so that we could see with confidence what had happened. We're looking at the waiver services authorized, and then if they received services by the end of that same period or not. And, you know, brain injury and related conditions, very small programs, small number of authorizations, and also not much movement in those programs. Each of them has a particular service delivery issue, which includes staffing, no doubt, but there are other issues, just not enough provider capacity there. We have a 9817 project going to expand brain injury services in Maine. Other related conditions, we think there are structural problems with that program and the cap on it, et cetera. We want to roll it into lifespan so that people are able to access higher budget and so on. So that's just for what it's worth. These are anomalies is what I'm saying. I'm sure a workforce is an issue there as well, but there are other issues. With section 21, you can see that we did better in terms of people receiving a service in the same period as the service authorization. And I would say that's likely because with section 21, if you get a slot, it's a priority 1 slot because you're at high risk, and there is a lot of effort that goes into finding you a place because you're generally at risk for abuse, homelessness, et cetera, for these folks. Section 29 really not, you know, looks like about fewer than half received a service in the same period as the authorization. If you look at the length of time before services started, you see a similar pattern here. Again, I wouldn't even pay attention to the brain injury because this is an N of 1. So that one person did receive their services, but you know, it's not meaningful. These 2 bars here are meaningful. And again, you see that much better. Here we did the cutoff at 90 days because unlike home care, it typically does take a while for people to, you know, the family might visit with 2 service providers. The decision-making process takes longer, and then matching them up with an agency that is going to meet their needs. So it's typically a longer process. So the blue are services started in fewer than 90 days. And then the orange is more than 90 days. So you see, again, the same pattern. People are getting services more quickly in section 21, but that's because of the urgency of the situation, generally speaking. And I think that's here. I mean, I'll just show you that there is archives for prior quarters, but the service data, this is only the 3rd quarter. I said 2, but we've done 3, I guess. This is the 3rd quarter, so we're starting to see some trends there. If you want to go back and look at that. So let me stop sharing if I can figure out how to do that now.
I can also help you stop sharing.
Would you help me stop sharing? Thank you. So I wanted to just finish by talking about the actually, one other thing that we have in progress that is very exciting is we now have just received from our vendor the results of our first fielding of the CAPS HCBS Experience of Care Survey. So this will tell us things such as, are you receiving the services that you need? Are you receiving them timely? Are you treated with respect? Do you feel safe, when you're with your caregivers, et cetera? So we have fielded a 9817 project to do 2 rounds of this, and we've just completed the first round in all of our waiver programs, all 5 waiver programs. It has been very successful just from a participation perspective. We had over 800 completed surveys in section 19, over 500 each in sections 21 and 29. These are going to tell us some important things about how the consumer experiences the service. And we plan to hold webinars soon to share the results. And we're going to run it a second time in the coming year so that we can see if there's been any trend. This is one, the HCBS CAPS is one of 2 nationally validated surveys that CMS has endorsed. And in the access measures rule that I'm about to talk about, this is one of the surveys that they endorse from which to derive access measures that they will accept as part of the reporting they're going to require under the access rule. So we're especially happy that so many people were willing to participate. We had some concerns about that. This was a phone survey. I think we had a good vendor who gave us good advice in terms of sending out information ahead of time to case managers and others who could advise people as to whether this was a scam or the real thing and all of that. But nonetheless, we're very excited about the CAP survey. So the CMS access rule, I know many of you have heard me talk about this before. We're hearing unequivocally from CMS and from the national provider associations that the rule is expected to come out in April. There was a draft published last year. Maine and many states and all the associations commented on the proposed rule, and we believe CMS is going to make it final here in another year. So the goal of the CMS access rule is to improve access and quality of Medicaid services, generally speaking, and it has a heavy emphasis on HCBS. And so we expect that we will be required to do significantly more reporting to CMS around access in our HCBS programs. It will include annual reporting on HCBS access measures that the state will have some choice in. Last year, CMS also published a state Medicaid director's letter with, I think it was 6 or 8 pages of measures that they've developed over time that would be standardized nationally. So we'll have the advantage of being able to compare ourselves to other states. And as I mentioned, it will include the option of using some measures that are derived from the CAPS HCBS. They will require us to report on waitlist data. And Maine's comment, along with many other states, was, well, you better define what waitlist is because every state defines it a little differently. So that might mean that we have to change our reporting depending on what definition CMS lands on. They're also likely to require us to report service initiation time. That's why we've been experimenting with what I showed you earlier. From a time a service is authorized, how long does it take to actually get it? It will also require a lot more public reporting. So not only reporting to CMS, but state Medicaid agencies are going to have to publish these measures on their websites. The compliance timeline is likely to be phased in over 2 years or so. So I see this as an opportunity to work with you all on what of the things that we need to report to CMS, which ones would we prioritize, in what order, so that we can start to roll these things out. I'm very wary, as you all know, of developing a lot of new homegrown state measures because we know that the access rule is going to require significant investment on our part in reporting systems. And so we will need to comply with the CMS reg, and we're hoping that what they're requiring we can not only do for the sake of reporting to them, but that it'll be useful to all of us as we try to learn more about access issues in Maine. So that's what I got.
Great, thanks, Paul. Questions from anyone in the meeting? Laura?
Thank you. Thank you, Paul. My question is about the length of time before services started information that you've shared, which is really helpful. It also sounds like you've been doing this for a couple quarters now, and I wonder if you have any trends that you're seeing on the IDD side. And my second question is, did you inherit and/or have the department or ODES developed any benchmarks that you want to set for the length of time before services started?
A slight improvement, Laura, and I think that that's really simply because, the first measurement, given that we're looking back in time, was really the darkest days of COVID, right? And so we would hope to see some improvement and very slight improvement. Nothing that I would call a trend yet. We're gonna have to keep going. I think in terms of benchmarking, we haven't seen any sort of national benchmarks that are broadly used. That's partly because of all these definitional issues, and every state defines things differently. So we're actually hoping CMS helps a little bit with this as they give the states definitions so that everybody is defining them the same way. But certainly, we don't want it to take 6 months to initiate a service. And so I would say my benchmark is better than what we're doing right now at the moment.
And maybe a follow-up?
Sure.
It's probably just more of a comment, to understand, especially when you were talking about, families or individuals having to, kind of shop around and find the right fit for them. So you can look at this in the context of workforce and go, well, and also how much is it that they have to go further afield because of, a shortage of staff and services. So, we think about community supports, a lack of those programs right now. So it's hard, I was curious if you have any anecdotal information about, there's the time of finding it, but as part of that time, because you actually, there are just fewer access to programs operating.
Yeah, I think these are just my impressions, Laura. So first of all, we do have geographical differences. We do have many of our newer agencies that are really seeking new clients are in the Lewiston-Auburn area. And so if you live in, Machias or Prescal, you don't want your adult child, right, to go all the way to Lewiston, although some people are making that choice. So the supply varies by geography. And I would say the best supply at the moment is that Lewiston-Auburn area. Let's see, the other part of your question. Oh, type of service. So I think, you all can tell me if this is an accurate reflection or not. I think providers have been trying to shore up their existing service lines, and then depending on the economics for the agency, they might be trying to shore up, the most viable part of their agency. My observation is that for most agencies, that's group home if they offer that. And so if they need to move staff off of community support and onto group home to maintain the group home, that's the choice most are making. But that's just my impression. And so, yes, we have had, and what you'll see in the HCBS CAP survey is you know, one of the places where we're not doing well is people saying, I want more help to get out into the community. And so that's not surprising to us.
Yeah, and we certainly saw that shift during the pandemic because community supports programs shut down and people moved to residential side. Thanks, Paul.
Yep.
Any other questions from folks in the audience, or not in the audience, in the room?
Yeah, I've got a couple, and just staying on this point, Paul, I'm curious in relation to time between approval of service and getting service. What happens to somebody who gets a service and then loses a worker? So I mean, I've heard Michael say, you know, he's had homemakers go into a home and walk right out. You know, so that would be somebody who got served, but then isn't served maybe for a long period of time. Do they come off the service list, or is that like a point in time and we consider that person served?
Well, in these data, it's a point in time, and we consider that person served.
That's what I thought.
Yep. That's part of the part of the challenge with these is, you know, you're trying to the service authorization is in one system. It's actually in many systems, but for a particular type of service in one system. And then you're cross-referencing that against claims. And those things have different time periods associated with them. So it's a very challenging exercise. And then when you look, you know, at the gap data request that you all made of us, is 16 sections of policy across 4 different offices. And so 3 of those offices have their own case management systems. All of it relies on MaineCare claims data, except for the state funded services where we're dealing with other claim systems. So I know you all are frustrated that we can't do that right now. It's an incredibly resource intensive exercise, which is why I say, I think, you know, nothing like a federal mandate to create the conditions in which we might get the resources to do that.
So I just want to follow up with something I think I heard you say, and so I'll apologize right up front if I missed that. I think I heard you say in relation to the people who are partially staffed that you don't know whether some of those people are unstaffed, and I'm looking at your report right now online while we're talking from last year, which has a clear column of people who are unstaffed. And so you knew that last year, and I'm just curious why you wouldn't know that this year.
Because we in response to quadruple A and our needs to report there, we added some reporting requirements for the SCAs. And we just did not, we sort of negotiated the reporting with them, and for ease of reporting, those 2 things were not separated out in the reporting. So this is what we get from the SCAs is the 2 things combined.
And so my last question is, what, if anything, are you all doing to engage with people who aren't getting care for a period of time? And do you, or if you're not doing anything, which is, I mean, you know, fine. Do you know what help, I mean, is anybody tracking these folks in relation to outcomes? Like whether people who aren't getting care, I mean, you have the utilization data, right? I mean, you can look behind the curtain where we can't, you know, is anybody tracking?
I mean, not that I'm aware of, Jess. For the most part, you know, we engage people once they begin receiving services. If they're not receiving services, we're certainly we're not able to look at claims. So I would say we don't do a lot to engage the folks who are not getting services.
Could I just add to that? I would also say, Jess, that for those that may be understaffed or unstaffed, of course, for Section 19, the care coordinators, so the SCAs are continuing their searches, especially for those that are understaffed. They're still there's the SCAs or the care coordinators are still required to reach out to individuals to ensure that, their health and safety issues if they arise. So I can speak to that. And on the developmental services side, for those individuals, they have a case manager. So those case managers, bill a Maine Care service. They don't have the same limits as some of the other programs. So they're certainly reaching out to the individuals on their caseload to see what other services they could avail themselves of. Especially, I think one thing also to note, I think Paul mentioned this earlier, even though there are adults with intellectual disabilities and autism on the Section 21 or 29 wait list, some of those individuals are accessing Section 19 services while they wait for those services.
And I'll just,
that helps.
it sort of does. I just will note that Betsy's not here, and anytime that comes up and people say that the people that they're providing care coordination for get case management services, she absolutely blows a gasket. They don't. They can barely, sort of keep up with the fact that they can't find workers and that they're not paid to do case management services. So, if someone needs immediate something and they are talking to them, they know that, but they're not doing case management services.
You are correct. They are care coordinators. It's a very different service.
Exactly. So I just want to say
Yeah.
those are very different services between behavioral health and the care coordination.
Paul, did you have something you wanted to add?
No, we can leave it there.
Okay. So, I think you have a hard stop, right, coming up in a few minutes. So, but I think I heard you say that your thinking is that when the access rule is out, this committee may be able to be a partner with you in helping to determine measurement points, and then is the vision that can be kind of extrapolated over into the non-HCBS services, or?
Yes, I'm making promises without consulting Michelle, which I shouldn't do, because the access rule also covers all other Medicaid services, right? So she and I will, and others in the department will have to figure out a process. We already are lining up some 9817 resources to make sure we can do a robust process in HCBS. And then we'll want to be consistent with what Maine Care is doing in other areas as well. But I envision a stakeholder process. I mean, because there are going to be choices that we can make, for one thing, under the federal rule. So we're going to want to know what your priorities would be. And then we're not likely to be able to do it all at once. And so, like, what's the most urgent thing, right? If we have to pick one measure we're going to work on.
Great, thanks.
Catherine, Arthur has his hand raised.
Oh, okay, Arthur.
Just one quick step for me before you talk, Arthur. I'm gonna give you permission and then ask you to unmute.
Hi, can you hear me?
Yes.
Great. Director Saucier, thanks so much for walking through the data reports that you just did. I wanted to just ask a quick question about the data in table 4 on page 17 of the third quadruple A report.
Okay.
And so, thinking about the percentage of members that are receiving less than all of their PSS and nursing hours, I'm curious if there's a way to get a finer handle on kind of what that looks like. Just in a hypothetical, these folks could be receiving 98% of their hours or 2% of their hours, and that would be a very different picture cumulatively. So could you speak to that a little bit?
Yeah, and the reality, Arthur, is probably the whole range is probably in those numbers, right? Yes, I mean, right now we're dependent on the service coordination agencies for that data. For them, it's largely a manual and difficult process. So we're trying to strike a balance with them in terms of what they report to us. But I think this goes to the resolve that Jess mentioned. I mean, trying to really do a good assessment of what it would take to get the data in the form that we want it to really look at what that gap is with more precision. So I think it's absolutely possible to do it with more precision. It's extremely difficult and resource intensive given our current systems, but we are very much interested in enhancing our reporting. And ultimately, longer term for us, we are starting the development process of a new case management system for aging services, so that will help as well.
That's really helpful. I appreciate that. And I'm very curious in contributing to this conversation and kind of building our knowledge on the scale of the care gap and trying to come up with creative ideas to get a better, a more precise measure of that. And, I'd love the opportunity to review whatever data does exist. I heard you earlier reference that broader data request that's too labor intensive given the department's resources, but it would be great to have an opportunity to review whatever data is there, whatever data does exist, to go into producing this report and see if we can kind of contribute to helping build that knowledge as well.
Great, thank you.
Thanks. And we will move along now. For Abby, I believe you are going to give the quadruple A report update. Is that an accurate? I struggle a little bit because I need my glasses to see up here, and then my whole screen where I have the agenda is blurry. So
yes. So Paul shared a bunch of the quadruple A report, and Jess put the actual full report into the notes. And then Angie, right after this meeting, I emailed you with it. I think Angie's going to distribute this PowerPoint to everyone on the committee, which is an overview of the report. So you'll sort of get it two ways, and Paul started with the nitty-gritty stuff in the back. This is more an overview of what the quadruple A report is, what it looks like. And I'm going to be brief, more brief than this full 15 slides going through what we had there, just because a lot of it has been presented before. And I was asked to talk about the credentialing effort and also our marketing effort. So that's all in here. So just to bring us about, so we reported on the quadruple A report to the DHHS Legislative Committee on February 22nd. These are the highlights. The report covers 8 general areas, but before I get to that, these relevant reports and resources, and it's not a PDF that I'll be sharing, it's just the PowerPoint, so that all the links hopefully work. If anyone has any issues, just let me know. The report is in response to the Commission to Study Long-Term Care Workforce Issues report, which is linked there. All the subsequent reports, the Home and Community-Based Services Improvement Plan, and the rate setting systems evaluations, you can link through all of those. So again, the report covers 8 general content areas, and the information to inform the statewide efforts come from DOL and then multiple agencies within DHHS. So it's not just us. I've been asked to touch, went too far. And Jess, I also tried to use presentation view and it wouldn't go to the right screen. So I've tried to make it as nice as we can get it here. I was asked to touch on curriculum efforts, which are under qualifications and training, and update you on the marketing work, which is in the recruitment and retention section. Happy to address any other areas if anyone has questions on those, although I may need to bring back some of those questions to the relevant departments, because again, this report does go through a number of them. So just clicking through, there are some bullet points for all of you to review on reimbursement efforts, the recruitment and retention bonus payment data that we have to date that we've shared on a blog. And then our marketing efforts are here in the workforce recruitment and retention section on page 6. So our previous marketing efforts were started by DOL and called Caring for Me. DHHS took over the marketing for a little over a year, and we're moving into the next phase of marketing the HCBS jobs and the profession as a whole. Those are the 2 mandates of our marketing work using 9817 funds. We finalized the contract with our new vendor, Broadreach Marketing, late last month, and are working to develop some new marketing messages and reassemble the advisory group so that they can help us think through key messages going forward. That'll happen sometime this spring. Members of the behavioral health workforce will also be added to the advisory council as we're going to expand the HCBS marketing effort to focus more squarely across ODES and OBH HCBS workforce initiatives. And then the other one is on page 10 with our curriculum efforts. So the third bullet down here addresses our curriculum work, which is addressed in the quadruple A report, and we have more updates. So Maine has been working on a direct service worker course, which will become the base credential for aging and IDD services. The goal of that course will be to use the CMS core competencies that overlap between service populations and create a more streamlined training for HCBS workforce. We plan to have a full draft of that course in the next month or so, and we're currently in the process of soliciting national subject matter experts to vet the course. So far, PHI and advancing states have agreed to look at the course and provide feedback, and then we'll have various other levels of stakeholder engagement with trainers and providers before it's fully launched, but we're trying to make sure that what's in the course is all the things that we want. OBH, as we mentioned before, was unable to join us in this initial effort, but because the course is squarely based around CMS 2014 core competencies, they'll be able to join us at a later date and build on some of the themes that are already in that entry-level course if they have the bandwidth later on. Again, most of these initiatives, all of the links to all of the things that are in this quadruple A report, and Paul spent quite a bit of time talking about some of the nitty-gritty data, are all in this presentation, which will go out right after this meeting.
Right. Thanks. Any questions for Abby? And is this what Karen, later in the agenda, we had the credentialing. Is this that too now?
Karen, yes, Karen invited, Karen joined us, was able to join us to answer any additional questions that we might have, but credentialing and marketing are both within the quadruple A report. So I wanted to give you a sense of the overall report and then those two specific issues, which I knew you wanted to be updated on specifically.
Great. I have a question on the credentialing. If I think last time you presented to us, we talked about provider engagement. My recollection was the only engagement with the provider community is to talk that you guys engage trainers that were employed by the agencies. And I think we were curious about engaging the general provider community. And I guess I think of these things from an operational perspective. If you're changing the credentialing requirements, that is pretty significant impact on what providers have to have, structures, investments, and whatnot. So I'm just curious about when that is going to happen, or if it's going to happen, and is it going to be we'll tell you what we're done, or is there opportunity where the provider community can advise on the credentialing?
No, that's a great question, Catherine. Karen, chime in if I get any of this wrong, but our initial plan is to make sure that we've created something that adheres to CMS core competencies, that is a good training product that teaches the things that we are hoping to get across for stakeholders, and then look to our stakeholders as part of our rollout plan to say, okay, we've created this great credential which goes across these two. How should the rollout process work? How are we going to be able to incorporate this into your training? Karen, do I have that about right? Did I summarize our stakeholder engagement plan?
You do, and I would also add to that, Catherine, as an update is, Abby talked about soliciting national experts to look at the curriculum. We have also had conversations with state providers as well to take a look at the curriculum and provide us feedback. So that once we, I think the plan was to look toward April. Abby, was that the last conversation? To start doing some listening sessions around the curriculum and the rollout. I will say, Catherine, one of the things I know you were just mentioning about, gearing up to what it is that you as a provider need to do. One of the things we're doing right now, and I think Abby mentioned this the last time, we're going to be able to use the state's LMS system so that providers aren't going to have to be concerned about where the content is, and we'll be giving individuals access to that site once it's up and running. In the interim, because that is not ready yet, we have solicited assistance from the Muskie Institute, because they have a platform, so that we can keep this rolling without needing to wait, if you will, for the state's LMS system to be ready for us to roll this out. And you are correct, there are some decisions that we need to make, and we want to also solicit feedback from stakeholders. So I think it'll be around April, probably closer to the end of April, before we start sending out notifications for stakeholders to be to come to the table and sort of hear about the project and all the next steps, and hear your suggestions and questions and feedback.
And then what is the timeline for implementation for this? Like, when do you anticipate the current credentialing being replaced for PSSs and DSPs?
We don't have a set timeline for that yet, Catherine, and a large part of that is because a learning management system and keeping this moving is a whole bunch of moving parts. We're still drafting the course, and the rough timeline that we have for finishing drafting the course is roughly by the end of this month, a little bit into April. May, start really getting into feedback and having the time to make those changes. We're hoping to have the course ready in June, but whether or not we have a learning platform, a learning management system in place is a moving part of this as well. We're trying to make sure everything aligns. That's a general timeline, which is why I say spring, early summer. But again, that includes having some of those stakeholder things and incorporating those feedback back into the course.
Okay, two more questions, because I get, but like from, and I'm talking from my provider seat and the board I sit on for Maxby, this isn't something we've gotten information from. This replaces Elsevier, the Elsevier platform. Is that the vision?
I'll respond to that, because I know that it gets a little confusing, Catherine. I would suggest that you have that conversation with Betsy and her team about Elsevier and the timing, because part of the moving pieces to this is the following. This is going to be what we would consider a base curriculum, but we also know that for direct support workers working in the developmental services world, there are waiver requirements for additional trainings. So I believe that those may stay with Elsevier or some other kind of platform. They won't be part of this base curriculum. So probably having those conversations with Betsy. I assume she probably joins your Maxby meetings, and maybe put that on her radar to talk a little bit more and flesh out with the group might be helpful for you and the other developmental services providers.
Okay, I'm just going to comment. It seems pretty strange to me that, you know, we just spent an hour and a half talking about, hour and 15 minutes talking about the workforce crisis, and 2 sections of DHHS ODES, what have you, is not working together and fully understanding the impact of the credentialing and onboarding of DSPs. So I would just encourage that conversation be had internally within DHHS, and we get a singular message. And then my final question on this is this more hours of training for PSS? Is this more hours of training for a DSP?
No.
Okay.
In terms of the base credential, again, there will be those additional modules as there are today for DSP staff. So in terms of overall additional hours, again, that's not our realm, so I don't have that answer for you. I think Betsy and her team could help respond to that, but I didn't catch your first question.
With all due respect, Karen, it's very frustrating to hear you say that's not your realm. When you're rolling out a new credential that greatly impacts a whole section of service delivery, I would think it is owed in totality, or DHHS in totality's responsibility to ensure that is done in a cohesive way. So punting it to providers to go to another part of your system is just really indicative of some of the challenges that providers face. I appreciate.
And with that, I can certainly, if this committee would like to have Betsy join this meeting versus a MAXP meeting to specifically talk about the curriculum for DSPs and those additional modules, I'm happy to do that.
Okay, thank you. Anybody else have any other questions?
I do see Arthur's hand up. I'm not sure if that's a hangover, hold up from the previous time.
Maybe a hangover too.
It's probably a hangover. I know it.
We're going into public comment, so we can move into that if the people on the current screen don't have any more questions. Okay, but I assume it's still up for a reason then. Okay. Arthur, do you have another question?
I do. I'm just going to disregard Jess's comment there, but I realized that I think I may have just been Arthur when I asked a question of Director Saucier. My name is Arthur Phillips from the Maine Center for Economic Policy. Abby, thanks so much for going through the quadruple A report and for putting all the work that I'm sure you did in summarizing all the work that you've been doing into one place. One question I have is, I think there was a blog from last June which kind of spelled out, it kind of showed some of the evidence of what the benefits of the HCBS recruitment and retention bonuses were. And I think it showed that through 2022, there did seem to be some real positive impacts from those bonuses that I think were, something like the average was $3,500 per worker. And it looked like the number of people working in HCBS it increased pretty significantly over that time period. And then when I think about that for the 2022 period, and then I look over to the latest quadruple A report for the 2023 period, I do see that there is some increase in certain sections in the number of people served, but there are some pretty significant widening gaps in care, at least from my perspective, without being yet being able to kind of dive into the data to my previous question about kind of, what percentage of care are those folks who are receiving less than all approved hours, kind of how deep is that care gap? So I don't know if you could speak a little bit about your impressions of kind of looking at what we found from 2022 to what I'm seeing in 2023 as being kind of a backward step, if you have any thoughts about that, and whether you anticipate there to be any further reporting on those bonuses, or what we have out there is kind of the accounting that we're going to have on that program.
Yeah, so I think you emailed me earlier in the week, Arthur, about if there was any other data, and I have made those asks to the relevant offices to see if there are any additional or updated data points on the recruitment and retention bonuses. And I just want to make sure I understand your question. You're asking if, the 1 year we did recruitment and retention bonuses, it seemed to have an impact, and now we've seen a change in the numbers. It's not for the positive. Are you asking if we're going to do recruitment and retention bonuses again?
I think it's more just kind of what your impression is of whether you think it's fair to say that we're seeing kind of going in the backwards direction after those bonuses have expired, or whether you're not confident enough in saying that.
Still, I'm not sure I understand the question. Just like, are you asking if the bonuses made an impact or not, or if we plan on doing them again? I just want to make sure that I can get the tie-in between the bonus data that you're asking about and any new directions.
Yeah, so I'm curious, kind of if you could speak to what you think the impact of those bonuses were, and whether what we've seen in the year following those bonuses in 2023, whether you think that backsliding may have been a result of there not being those bonuses continuing.
That's interesting. I would say that we don't really have the empirical data to really answer that question. What we saw with the bonus data was that there was a correlation between more people entering the field and those numbers. And without them, you could see the correlation down. That's about as far, I think, as we can push that data, really. And I think from a sort of a more qualitative level, we heard from some of the providers and folks actually who are on this call right now that they were unsure about the place of the recruitment and retention bonuses and their impact on the field, whether or not they really made a difference or not. So I would say, a great part of empirical study would be just sort of asking those questions to provider agencies maybe about what that was, because I don't think I have data to answer that particular question.
Thank you.
A follow-up to that, Abby, is, and I was luckily I was at the HHS committee because I could hear your report, but the slide and that you had on that, I thought it said that the initial, your initial data is that it helps stabilize. So is there more that you're doing to determine that, or is that is that door kind of closed on that and we're moving on to other stuff at this point?
Yeah, I'm not sure. That was the initial data that we had to publish the blog. And per Arthur's email, I've followed up with our office internally to see if we are publishing more data on that. I don't know the answer to that question, but happy to follow up on it.
Okay, great, thanks.
I'll just say, I thought that was your presentation to HHS as well, that the bonuses clearly had an impact.
Yes, my presentation verbatim was that we can see a correlation that they did have an impact. It would appear that way. I think I was asked a question specifically on causation, and I don't think that we can definitively draw a causal line there. However, the correlation is pretty strong about the impact that those bonuses, those recruitment and retention payments had on the field.
Any other questions folks have? Okay. I think, so Abby, I think you've done all of your parts, right? Like later on, it was caring for me transition. You've done that now too, right? Just trying to.
So, yes.
Okay, cool. All right. So the last remaining presenter we have is Kim.
Dun, dun, dun.
From DOL, and why don't you go ahead?
Sure. Just got a quick update for you. I don't know if anyone else hasn't stood since 12:30, but boy, really would like to stand. All right. So it looks like I am screen sharing, and I have a handy dandy TV in front of me that tells me I also am. Let's see if I can do this correctly. So I'm going to give you a quick update on some of the things that I usually update you on. I'll break it down for you. First, healthcare training for me is that overarching partnership with HHS, community college system, adult education, us, the university system. So that's kind of the overarching. And then we have, of course, segments that we specialize in as well. And I'll give you an update on our specific sections as well. So let me scoot down. That didn't work. Hang on one second. There we go. All right. That used to say Google Analytics, but I apparently have deleted the G. These are actually Google Analytics, not Google. So these are Google Analytics from April 15th, 2022 to 2024. And a little bit further in my presentation, you'll see a last 90-day snippet, just again for reference. So quick overview. Let me scoot you guys out of my way here. Oh, there we go. So quick overview, since the launch of the site in 2022, we have seen 34,756 unique users. Average time on the page is 2 minutes and 10 seconds. That's usually not too bad of a thing because really we're trying to call them to action. We're trying to call them to do something. And often that something is not actually on our page. It's on somebody else's page, or it's a training provider. It's a, hey, tell us more, tell us how we can help you. You can see that the ongoing training page, which is kind of where we break down what are some of those really quick short-term credentials, what are some of the longer-term credentials, usually a year, 18 months, somewhere right around there. And then what are more advanced credentials to 4-year degrees. That page has been our most popular page that folks have been going to, which is great. Homepage also has a lot of really unique information on it as well. Kind of gives you a nice overview. So some folks are starting there. The funding page, that is a unique page that we have. It doesn't mean that that's not an access page. We also have a really cool survey for both employers and job seeker, or sorry, I'll call them students, job seekers, whatever you want to call them today. But for workers to go ahead and click. And so just because they didn't click on funding doesn't mean that we have not had a ton of funding requests. And we'll talk a little bit more about that in a second. Other programs, and then Angie, that's Spanish, right?
Portuguese.
Portuguese. We did have a couple folks who clicked on Portuguese, which is great. In the last 90 days, so we know this is still continuing. This wasn't a one-time thing. We did a blast and everybody landed on it that month. Just in the last 90 days, we've seen 4,500 first-time visitors to the site. They did hang out for a bit. They looked at 11,000 pages, so they've looked at 2 1/3 pages on average. We do see that most of them are using our site in English, but we did have 15 individuals who accessed it in Portuguese, 13 in French, 6 in Spanish, and 2 in Arabic. This is an interesting slide, or interesting piece as well. How did folks actually find us? Some folks are doing an organic search, so they're searching around the internet and they're finding us. Some are getting to us from referrals, so we can see that the former Caring for Me campaign, which the page is still up, we're still getting some referrals from it. Just like the Live and Work in Maine campaign, we're seeing some direct referrals from that, about 1,700 or so referrals there. Some of them are just searching for it because we've said it in a workshop, we've said it to an individual, and they're typing in the Google healthcare training for me, and they're going straight to the site. And 9 have clicked on or have come through an email. Oh, did I delete the wrong one? No, this is right. Diving into referrals. So where did they come from? This talks a little bit more about how we got them. So how many clicked into I'm sorry, I should also point out, this is even a smaller segment. So if you look at the dates on this, February 14th to the 20th, March 11th to the 17th, the users who accessed the page that day, where did they come from? So primarily from Google. And then I have you guys over my screen here. You can also see the direct. We are lucky to know that while the sources are awesomely diverse, we're getting most of our referrals through Career Center web pages. So folks are finding us through, they might have just been laid off. They were told, hey, Career Center is a great place to look for resources, and they're finding us through that, which is really cool.
Shout out to Sally, who's still on this call, who helped us refer a few people as well. So thanks to the Maine Hospital Association.
Awesome. All right. Oh, yes, they're right there. Nice. You guys made the list. All right. So which resources are most used? Ongoing training, the homepage. I think we already talked about this. I think I meant to delete this slide and I missed it. And did I delete the wrong slide then? No, I did not. So again, overarching healthcare training for me. Over the course of its existence, we've received 2,102 worker applications. So folks who said, you know what, maybe I haven't talked to my employer yet, or I've left the healthcare field and I'd like to get back into it. They're folks who found us organically, workers who found us organically. And then 166 employers have applied on behalf of their staff. They've submitted through tuition remission and healthcare navigators. So some of them are looking for, hey, I don't know exactly where I am or what my next step might be. And others are saying, you know what, I know exactly what I'm looking for and I wonder if you can help me pay for it. Individual workers right now, we have 180 active. We have 1,851 that are closed and 71 that are on hold. And the on hold are usually waiting for a class to start or Angie's awesome team getting a class initiated, actually developed. We've had a lot of successes there. Employers, we've had 100 connected to a training. 8 are actively working with a member of our healthcare team to get that training started. Then, specifically to DOL programs, we have the 2 sides of the coin. We have our healthcare navigators who are helping individuals who are interested in the healthcare career. Maybe they're looking at the next step in the healthcare career. Maybe they're transitioning from another job that they got laid off from. But 270 individuals have received a service through them. And of course, we document that in the job link, which is a huge benefit because it gives the ability to do a little more analysis than some other folks can do. So we know that we are planning a little deeper dive of the results of working with these individuals, or the results of these individuals working with the healthcare navigators. Did we see a move from unemployment to employment? Did we see an increase in wages? Did we see credentials earned? All that kind of stuff. So we know that 470 of those folks were referred to training opportunities. 46 needed some support services to get them going. And then 269 have been referred directly to jobs. And huge shout out to the healthcare navigators. They have some pretty awesome relationships with employers, and they are literally making those connections directly. It's pretty awesome to see them work. We're super, super excited to have sector specialists embedded in our career centers. The other side of the coin is the tuition remission program. So that is where we're able to support funding requests for healthcare providers or workers or interested workers, those who are either reentering or currently in the healthcare field, to help them get a credential or skill in their credential. So, so far, you can kind of see the breakdown. Angie may have put these slides together, so I'll give her credit. So Angie was able to kind of hone in on what we might consider to be direct care careers and how many folks that we've supported or how many credentials we've supported in those areas. So we have certified alcohol and drug counselors, only a couple there, but still growing. MHRT, 162 folks. ACRE training, which is specifically for folks with disabilities, or for supports for folks with disabilities. We've supported 117 individuals there. Certified dementia care, which is the one I am so happy about because I know it's a huge need, and we finally have. It's been a huge concerted effort, and we are super, super excited to support that one among lots of others. But we have 2 folks certified there. PSS's 29. Foot care specialist, which is a really cool one as well. This happened, I'll tell the story, happened to be an RN who wasn't necessarily able to use her full skills as an RN anymore, but she's very interested in staying in the field, and she was able to gain the certification to be able to work in some of the facilities to be able to provide this really, really specific care. And with the background of an RN, that's pretty cool. So super excited to support her in that. Also super excited that we have trained 121 LPNs. Also have gotten LPN programs started up both at SMCC and continue to support the one at Northern Maine Community College. Super excited about those. 88 CNAs, and then CIC infection preventionists, only 1 there, but also, if you have a need, please let us know. We'd love to support that one as well. So among all of our enrollments in tuition remission, we have about 48% representing direct care workforce. So, I think that is the end of my slides. I'm going to stop sharing because I found the button. And if you have any questions, I'm happy to try to answer them or to put to Angie.
Angela's got her hand raised.
Yeah, thanks. Thanks for the presentation. I was wondering, Kim, if you could tell us more about the dementia care provider credential. We sometimes get questions about that. I would love to know more, like who's doing it? How can we connect them to this resource? That'd be great.
Excellent. If Angie doesn't know the answer, we're going to get it for you.
Yeah, the 2 folks that we've trained so far have wanted a very specific dementia care training that they found themselves, and it was with a private training provider, and their employer said that it would help them advance in their career, and we were like, sold. tell us how much to pay for you to get this training that you need in order to advance in your career and better serve clients. So I can email you, I don't have it off the top of my head, the names of the training provider we used, and I would love your help to spread. I've been thinking about like dementia care and the CIC infection preventionists as being so low. I would love, and so affordable for us to do and easy for us to support. You know, I'd really love to see mostly important to the field, right? It'd be really lovely to see if we can grow those numbers before the program funding sunsets in December 2024.
Yeah, maybe we could take this offline because I have a few thoughts, but yeah, that'd be great.
Great question. Thank you so much.
Any other questions folks have?
Well, you know, I'm just gonna, I didn't see DSPs on that list. Are they not part of the work, or did you?
DSPs don't need our funding for tuition remission because it's currently free with DHHS. So at the end of this quarter, which is coming to a close very soon, I'm looking to put together a chart that kind of shows what were the investments that the Maine Community College system made with Maine Jobs Recovery, how many people were trained from DHHS and BHP, DSP. So we could look at that total picture of what the direct care positions are, but unfortunately our slice of the pie is just what we paid for.
Yeah.
Or not unfortunately, so what I can tell you about.
I think that would be really helpful. I know, you know, just speaking from our agency, we've tapped into the Alphon funds for DSP training because it still costs us as an agency to provide the training. Like the curriculum's free, but the time to teach the staff is so that is that's interesting that it's presented as it's something free from DHHS. So, but
I see Angie taking notes. So
yeah,
I think
so
we work super closely with Alphon.
Yeah,
we often
it's
are
been
the other
great.
half.
Yeah, it's been great. So, and then I had a question was when does this come to an end? And is there any? And I heard you say it right, December 2024. And is there any appetite for continuing any of these programs post whatever's
Plenty of
funding them
appetite. These are funded 100% by Maine Jobs and Recovery
Okay.
funds. So these are federal funds.
Right.
So it will be one-time funding. That doesn't mean that there aren't opportunities to partner with other existing programs. So for qualified individuals, we still have WIO, we have competitive skills scholarship, of course we have HOPES, we have parents and scholars. We've got lots of different opportunities. It would work. It would take working closely with one of us to help you through the alphabet soup, and we're always happy to do that.
Yeah. And I can just say we have a LPN at one of those 121 LPNs at our agency, who was somebody who was a DSP, and then became an LPN, and so I think it really served it well. It's doing great, great job, and it was a great opportunity, and was able to stay within our agency to do that, which was really nice.
Fantastic. Good to hear. I think I see Sally.
Sally has her, yeah.
Hi, let me lower my hand. Thanks so much. This is great information. This is just more a comment. I just because I've been talking to a lot of people about, you know, how to get people in the pipeline. How do we leverage the resources offered through the Maine Department of Labor? How do we get folks interested in taking that leap? And it's really been interesting because the past few weeks I've had like 5 conversations with folks that are the ones that are running the program. So not so much you know, the provider side, but the educator side. And something that they keep kind of saying to me is a couple of things. And I know this funding is limited to this, but I think if we think, I'm kind of putting this out there to the group as something to like chew on, is lots of opportunity for tuition. That's not the barrier. Getting your tuition paid for, that's not the problem. 2 major barriers that these educators are telling me about, and that is the cost of living and life, housing, childcare, And that even if you have your tuition covered and your books covered, you have to give up time at your job to then go to school. And there's some of this cost that is really keeping either students from entering a training program, or it's adding to attrition. Once they come into the training, they're leaving before they finish because those barriers become so significant. And another piece of that, which I think is kind of interconnected, is really a lack of satellite or what am I trying to say? Like sites that are not requiring students to travel. So this is something I've been working a little bit with hospitals to try to figure out how can hospitals create educational sites in partnership with educators so that folks don't have to travel 45 minutes to go to a class, but could maybe go to their local hospital and access the technology required and be with other students who are also learning at the same time. And what is that number needed to get there? But I think that these are real, I think it's almost like we can throw all the tuition we want at folks. We can do all these things, but at the end of the day, if they can't access the training because of travel or time away from home, or they continue to struggle with paying their bills and gas and feeding their families and paying their rent, like, I think that is going to be an ongoing thing. And I think it's something as this group, stakeholders, as we think about how do we approach this in particular, how do we support people who want to do this work? I think we need to get a little creative in those areas. And I don't know what that looks like, but I'm just putting that out there.
Yeah, so it's a really well taken point. I mean, we do have programs. They certainly cannot cover everyone. But for the folks who do qualify, whether they're low income, laid off workers, individuals who otherwise qualify, we do have support programs that will help pay for transportation, childcare, the equipment, the stethoscope, the shoes, the whatevers. Did I say childcare? Childcare. Yes. Yeah. There are programs in the school. We are working so closely, but it's never close enough, so closely with the schools to make sure that we get connected to those students so that they know that those opportunities exist and they attach to them before they have to inevitably bail. It's a struggle, and anything that we can do to partner with you to make sure that as you're hearing educators say that, we want to make sure that they know about all of the opportunities that do exist out there, but again, acknowledge they're not going to be everybody's answer, but it will be the answer for some of them.
Great, thanks. And I feel like there's a lot of opportunity for that, to bridge different, different areas and just having so many associations on today. And I think it would be great future work for the collective community. And almost in particular about that, like a roadmap, because I think that's what people say. They just see all these barriers to being able to do something, and it's really hard as an employer to help them navigate them through them. So anyways, the more we talk, the more we learn. Great.
So speaking of which, we actually, we haven't nailed down a date, but we're hoping to host through the Essential Workforce, no, what are we, the partnership for, I don't even know what our name is. That's terrible.
The other group.
Yeah, the other group.
The other group.
I'm brain dead. This is my second 3-hour meeting, so I'm feeling the press of it all. But we are hosting hopefully a conversation in June, late June, exactly to do something like that, to create a bit of a roadmap. Beyond, by the way, state government and providers, but how do we engage others, business leaders and municipal leaders? I know that sounds odd, but there are solutions across sectors to some of the things, Sally, you were just talking about. And then also just sort of thinking differently about the delivery of services and who pays for that. is another sort of thing that we're really talking about. So stay tuned for that. It's sort of in development right now, and we'd love to. I can talk with you more about it offline.
Wonderful, wonderful.
Obviously, I will share it with everyone as well. We're not quite there yet.
Yeah. So we're at the point in our meeting where we have our final public comment. So Angelina, can you see if there's any comment from, oh, Jillian. Hi, Jillian, you want to go ahead?
Yeah, good afternoon. So I was just, I listened to your whole meeting and some feedback at the end, and I kind of heard you talking about the bridge, and I just do want some level of discussion or communication around like the circumstances where people come in with really high level degrees, doctorates, nurse practitioners, nurses, and they can't work as a personal support specialist until they test out to the lower level credential. It's the same thing we've been having to do with the CNA, because they're not on the registry and we can't use them by a licensing standard. We have to test them down to a PSS. I just know if you're like unleashing these new trainings, there should just be some consideration on how people come in so overqualified and we can't use them. And it's like, I've had nurse practitioners come in and I say, you have to test out, and they like laugh at me. And it really is something that needs to be addressed because they're so overqualified. It's kind of crazy for me to have to skills test somebody with a credential higher than mine. But we see this in the industry across all, services, DSP, PSS, DLS, just people have big credentials and they don't translate into a 40 or 50-hour training. And I just think that needs consideration because it happens a fair amount.
Jillian, can you explain that for some of us on the committee a little more, like an example of that?
Yeah. So for example, you have a registered nurse come in and they are a registered nurse. They do not have a PSS credential. You have to test them out in a skills lab and have them show you all of the skills on a PSS checklist to make them able to have a PSS certification to do the PSS job, or they don't align with Maine Care rules that they have to have the PSS credential. And it's ridiculous because when you go to nursing school, the first 2 years of your school, right, to get your associates, the first 3 months you become a CNA. I don't know if that's still the case, but you have a CNA. It's a higher credential than a PSS. I also have to test out all my CNAs. So if I don't know what the credentials are now, but like say it's 180 hours of training, I have to get them in a skills lab and have them complete without any teaching to them. They have to show me 100% that they know the skills to be a PSS. And to be honest, I think in some circumstances, a DSP can test down to a PSS if they can show that they have those skills. It's just kind of evolved over the year where I've like worked with the department to say, can I test this person out? And then it requires a lot of discussion. And yes, you can. It's just, as far as I've had people with PhDs, I've had people with nurse practitioner degrees, and they all have to be tested down to a PSS. And so it could be somebody with any high-level 8-year degree that's far above that of the staff that's doing the entry-level job that had all of that training in their degree. And you can't work them until you put them in like an 8-hour skills lab with a test and an exam. And it just needs consideration because these people could probably be teaching the courses. Admittingly, and it's always overlooked, and it tends to be middle-aged, retired people that got the degree. They don't want to use it. It might be their mother, their, a family member. It tends to be, but they just kind of fall through the cracks of being way overeducated, and then I have to put them through something that they could literally teach the course on.
Do you see that primarily with PSS workers?
No, I see it. Well, if you're talking any level of worker I employ, I see it with MERT-Cs, with adult case managers. I mean, they might have a 6 or 8 year degree, but they can't be a MERT-C without jumping through all kinds of hoops. I mean, I've seen it with daily living skills workers. I mean, you know, they got to take, say, 50 hours of curriculum and X, Y, and Z, but they have a bachelor's. I see it with, it really is in almost every job I offer, that people come in with a higher credential that seems like a no-brainer, but they can't do the job.
So can I get,
I'm curious. Oh, go ahead, Jeff.
Well, I was just gonna say, I think, you know, it's 3:50. And we may have other public comment, but we might not. But I'm also just gonna say, I think this would be a great topic for future conversation. And it's certainly something we could make a recommendation about to Maine Care, Department of Health and Human Services, or licensing, or whoever we need to make a recommendation to.
Yeah.
But I think we could spend some time digging down on this. So Jillian, thanks for raising that. I think there's, you know, I'm guessing we could do a little inquiry and put together a recommendation from this. So.
And look at other states too. Like a lot of times when I have people relocate to Maine, that whatever they had from another state doesn't translate to what Maine is requiring. Like I know New Hampshire does like an LNA, and I always have to like seek out guidance on, is that like a CNA and can I test them out? And so there's just other states that have other credentials or degrees that also don't translate to Maine and need some level of translation so they can move here and you can employ them.
Okay, good, great. Thanks, Jillian. We'll put that, I mean, then only if there, is there any other public comment? Okay, so the last item on the agenda is agenda items for the next meeting. And I think we have chair's election is already an item. Maybe we can add credentialing, you know, that conversation, bring that conversation back to the next meeting. And are there any other agenda items committee members have that they would like added to the next meeting agenda?
I think we're supposed to vote on chairs today.
Oh, we vote on chairs today? We don't have a quorum.
I was thinking that too. So we should, I guess we'll have to push it off till the next meeting. So yeah.
Okay. So if anybody has chair ambitions.
Yeah.
I think it should be Jess again.
To get yourselves on the ballot.
Yeah.
I heard Jess say she wanted to do it.
I heard Angela say she did. Yeah, no.
Is that voluntold? No.
Angelina, do you have when our next meeting is scheduled?
I do. That is an excellent question, and I
mean, I probably have it too.
I'm scrolling very quickly because I'm pretty sure it's June.
It's June 19th, I believe.
June 19th. Yeah, I was just gonna say.
Which is Juneteenth, which is a holiday.
Hey, right.
I think we had already talked about that, and maybe let's look back in our notes. I think we talked about moving that. I thought, but
I think we did too, but it's not on my calendar, so.
I could send an email to the committee members after this meeting. I actually think this is the last reservation we have in the calendar for these meetings because of, like, I might have not made them for the next 6 years of our lives, despite the legislation. I might have just made them for a year at a time. I can circle up with folks via email and have people vote about a June date that's not a federal holiday. And so then also possibly seeing ourselves in September, or even finding a new rhythm that gets us closer to the that would maybe have our December meeting not be at the very end of the year right before our annual report is due, maybe like a little earlier in the quarter than at the end of the quarters.
Sounds great.
Okay, it's just me dreaming over here.
You want to send out a suggestion for that, and when you send out the email?
Angelina, that sounds terrific. All of that is good.
All good. Great. All righty. Well, anything else anybody has? Thank you to our guests. Appreciate it, as always, and we'll be back at it. Have a good day.
Thanks, everyone.
Hope you feel better, Dylan.
Oh, thank you. Yeah, it's been miserable.
Oh, I'm sorry.
I'm glad I did not decide to come in though. So none of you want this.
No, we don't want it, no. And yeah.
Well, next time. I talk to you soon. Take care.
Okay, take good
Bye,
care.
Dylan.
Bye.